a conversation that we're having this morning is going to be helped looking at chronic disease care in Kenya. On the rise, on the increase. But before we get into the details of it, Faith Okwisa Okwayo is here with us this morning. She's the chairperson of the Chronic Disease Society of Africa, and she joins us this morning. Faith, good morning.
Good morning.
How are you?
I'm great.
Karibu sana. Thank you so much for being here this morning. We will be looking at a number of issues, but before we do, let's welcome you to the show properly. You've done an amazing welcome for us here this morning, and it's just really good. I mean, I'm still gobsmacked, and it's just great to have you here. Thank you so much. You've come, it's typical African, don't come empty-handed. My mother and father used to tell me that all the time. You don't go somewhere empty, but it's really great, and we just wanted to recognize you for that.
You're welcome.
And as we get into it, CT has a proverb.
I do.
He goes to a different African country every week. And when he comes with proverbs. So he'll tell you where we are this week. He'll tell you the proverb. And then we'd like you to interpret that for us.
Okay.
The proverb
You will
is very
survive,
simple
don't worry.
and straightforward.
Yes.
And what we want is your interpretation.
Okay,
not the
amazing.
interpretation you think we want to hear. Okay? Yours.
Yeah.
If I say something and you said, I saw a bird flying in the night.
That's okay.
That's it.
That's okay.
Yes, it's fine. That's what you saw, isn't it? At least so
Yeah.
you tell us. We are in the Islamic Republic of Mauritania. I've been looking at countries in what we refer to as the Coup Belt. That Coup Belt, it's literally a belt because it's from the Mediterranean right up to the Atlantic Ocean, all those countries. And they're characterized by one thing: they've had very many coups. One coup attempt, elected government is told, take a break. And we are seeing it even right now in Sudan, because Sudan is actually part of the coup belt. Okay? Now, the thing about, it disturbs me. It disturbs me because you look at these countries and the problems they have, they're all rich in minerals. Even though this particular country, close to 90% of it is the Sahara Desert, but they're rich in minerals. And yet, their people are some of the poorest, and the country itself is one of the poorest countries in Africa. You see, poverty is measured in the people and their livelihood and their well-being. If people cannot even get certain basics, then you're definitely poor. It's not measured by the people in the country who tend to be obscenely wealthy, not those ones. Anyway, the proverb. The bigger the head, the bigger the headaches.
Wow.
Yes.
The bigger the head, the bigger the headaches.
Yes.
I think my interpretation will be when the head is big, it increases the surface area for pain.
Very good. Do you think people who have big heads know they have big heads? Or if my pain is excessive in the head and I know that my head must be big, that is why I have a headache.
Technically, I'll agree.
Like
directly proportional.
Yes.
Yes.
Okay, now apply it for us. What do you think they're trying to tell you?
In relation to the country.
In relation to anything that you choose.
Okay. Let's say China, for example. It has a very huge population, arguably among the top 2 in the world. So the multiplicity of the burden in China is dependent on how many people are there. And even if I relate it to Africa, though Africa is not a country.
You know, you've given us, this is the thing about asking people to give you the opinion. My mind I've never gone there.
Didn't, actually.
But now that you mention it, it's so very true.
Yeah.
True. It's so very true. Yes.
The fascinating human mind, essentially. So I think this will feed into conversations that we have this morning. And so, Faith, you are the chairperson of the Chronic Disease Association of Africa. And so when we're looking at the burden of chronic disease in Africa, I want to do an overview, first of all, because chronic disease has come into the conversation 10, 15 years ago.
Yeah.
We didn't really talk about it much until we started to see prominent people And for me, everybody in society is prominent. But when we talk about it in terms of, people who lead, people who, are outliers, people who hold particular positions, when we started to see that those folks, and this is not just in Kenya, this is across board. When we started to see those folks affected by some of these chronic disease, then we started to sit up and pay attention. Leave alone that we had Abuja conventions and things like that, and declarations and, things that happened in Maputo and Gabon. Put that aside in terms of what we're going to do medically. But when we started to see that prominent people started to get affected by some of these chronic diseases, we sat up and started to take notice in terms of what happened with its care. But let's look first of all at overall. When we talk about chronic disease, what are we talking about before we even start to go into some of the work that's being done?
Yes. Thank you for asking. And even before I go into what chronic diseases are and what the burden is, we have to look at Africa. And you're saying we started noticing chronic diseases in Africa when prominent people will probably fall victim. Why is that? It's because the way we have approached the disease burden in Africa was always vertical. We always looked at disease burden in Africa based on the infectious epidemics. So chronic diseases have always been here with us, maybe not to the scale as of now, but we never put them at the forefront or at the front line of our solutions because they were not affecting the people who quote unquote matter. Yes. And the way we're approaching diseases of vertical, like would only depend on what the global health diplomacy was angling towards. Let's say, for example, the heavy funded diseases were the malaria, the HIV, and the maybe tuberculosis, which some of them are both chronic and infectious. Then would maybe put the lifestyle diseases at the bottom line.
Okay. Yeah. So when we talk about chronic disease, what are we talking about?
We're talking about any disease that you have to depend on medication for survival. It's a self-management disease. It's a disease that does not have cure. That's a chronic disease. And we have a myriad of diseases. The spectrum is huge, over 26 diseases. There's so many, ranging from cardiovascular diseases to diabetes, to lupus, to even sickle cell anemia, to cancer.
But is cancer a chronic disease? Because cancer can be cured. It can be, you can be cancer free. But is it named as a chronic? I mean, we see that it's often lumped in chronic disease, chronic and critical care, and cancer finds its way there. But is it a chronic disease?
Yes. Okay. I would say cancer is a chronic disease because even though you're cured, you are under remission.
Okay.
The chances of resurgence and recurrence is high. So long as you have, and most people who've gone into remission of cancer are always maintained on certain drugs. They're not necessarily not taking drugs.
Okay.
Yes, to be able to live a quality of life.
Yeah. So when you talk about chronic diseases and the burden that there is, one would just beg to ask, what causes them?
What causes chronic disease? There are so many factors. There are so many risk factors of chronic illnesses, ranging from genetic predisposition, environmental factors, lifestyle decisions like exposure to risk factors like smoke, for example, and maybe even our diet, which is not 100% absolute the cause of chronic disease, but it's a risk factor.
Okay.
Yes.
So with the risk factors that are there, because I know now one would go granular in specific disease that one is dealing with, but now that brings forth the entire conversation on research and development in terms of just understanding what affects us most and having data on that and be able to respond to that. So as a body that deals with this on a daily basis, where are we in terms of research to know our burden when it comes to NCDs?
So I'm not very encouraged about the burden and the sizing that we have, because to start with, we do not have a definite burden. Let me tell you something. You'll find even from the Ministry of Health and our research institutes like KEMRI, they rely on WHO data to tell us what's the burden of a certain prevalence in Kenya. Like if you go to certain bodies that's supposed to know the actual data of diseases in Kenya, you find they're saying, according to WHO report, which is 5 years old, our disease burden is this and that. So our disease data is not live. Our disease surveillance is fragmented. Yes, so we don't have a definite burden. So as Chronic Disease Society, we are disrupting that model and trying to go into communities, facing the people from the grassroots and understanding what is the burden as we update our live database.
Okay. So when we're looking at some of the chronic diseases that are then prevalent in Kenya, and we look at that, some of that information that actually is available, we're looking at cardiovascular diseases, and we look at things like hypertension, high blood pressure being one of them, the big ones. We're looking at diabetes, chronic respiratory diseases. We're looking at obesity also being particularly common, and that you have to then deal with something lifelong to be able to take care of them. Now, when we look at, because every country then has its own where these chronic diseases are prevalent. And if you're looking at the entire continent, if you're looking at the western part of the continent, looking at the southern part, there are diseases then that, are prevalent in those particular areas.
Yes.
Now, if we zero in on Kenya, and we've seen this grow, we've had conversations here about diabetes, we've had conversations about hypertension, high blood pressure, we've talked about other heart health, issues. The question would be that if we know that these things are prevalent in certain countries, and because you represent, the continent, if we know that these diseases are prevalent in certain areas, what is being done to ensure that, number one, there's enough research around them, that there is enough in terms of treatment care, and that there is enough about knowledge and awareness being done to say, these are what they are, this is what we should be doing to ensure that they're taken care of?
So a lot is not being done as effective as it was done on other diseases, like, let's say, when we are combating HIV, for example, which was a USAID heavy funded program. You find so much interventions are done, and there's a treatment pathway from diagnosis all the way to disease remission that is there. But for chronic diseases, it's quite fragmented, and we are trying to introduce policies and let's say, for example, global health diplomacy policies that will combat these diseases, because there's a cross-border effect. There's some commonalities between countries of different burdens. So, for example, let's talk about obesity. Obesity is a disease that predisposes somebody to 18 other chronic illnesses.
Okay.
Yes. So the first strategy you will have is preventative health, because if you prevent people from getting to obesity, then you're preventing 18 other chronic illnesses. They are called multimorbidities that come from one particular disease, especially the metabolic ones that expose you to other diseases.
Such as what? Now, let's look at, so if you're looking at essentially the father of them would be obesity.
Yes.
What are some of the things that we're seeing that would come as a result of these?
So obesity, of course, makes you have a lot of visceral fats. And some visceral fat, there's fat that's good and there's fat that's not good. So visceral fat is not good. Visceral fat makes your organs vulnerable, like your liver function, your kidney function, your heart function. When you have a fatty heart, fatty liver, it's not optimum. So you find you end up now having hyperlipidemia. So there's so much lipid being produced. Lipidemia and hyperinsulinemia, which causes diabetes.
Just break them down, please.
So hyperlipidemia is when you have a lot of lipids than you need. Hyperinsulinemia is when you have too much insulin that leads to insulin resistance. Like when you have too much of something in your body
so how do
you don't need.
How do you have too much liquid in your body, and how do you measure when it's enough or when it's too much?
So basically, when you're taking, and I didn't want to go into the nutrition discussion.
The reason why I'm mentioning it is for our audiences to hear and understand, because some concepts may be easy to understand to somebody who already understands. But when it is spoken of, someone says too much liquid. What should I not drink? Water? What should I?
No, too much lipids. Fat.
Oh, see, liquid.
Lipidemia.
So what I mean is the gut. Okay, let's go slowly. Right?
Okay.
The gut is from the mouth when you eat your food to the level where you remove your food from your body. So the gut, from the time we ingest our food to the digestive system, I think you're familiar with that. So that process is what exposes us to 70% of diseases, because our immune system is literally within our gut. So when we take care of our gut, which is now what causes obesity, the gut and other metabolic functions, because also obesity is a chronic illness, meaning you don't cause it upon yourself. It's about your hormone balance and all that. So when you ingest food, if you're mindful and well educated, that's why we're doing a lot of patient education. From the time you're eating and you're aware, bringing awareness and self-management to yourself, then you'll prevent a lot of diseases just by being aware.
Okay.
Yes.
Now, I want to graduate this just a little bit, because there's always the awareness that you built amongst yourselves. If I suffer from something, CT suffers from something, then you're taking that responsibility and you're going to, you're seeking care, and somebody's dealing with you here. But when we talk then about an umbrella whereby the people of a nation are supposed to be taken care of, in terms of spreading information and communication, in terms of making sure that initiatives are out there. We know, for example, the Ministry of Health in Kenya, under the likes of Dr. Mtandachero, for example, are leading initiatives around preventative care.
Yeah.
Now, when we talk about preventative care, that means it's very important for you to know the quality of the food that you eat, the source of the food that you eat, and spreading that information around. But are we really doing enough to understand some of these things? A lot of these initiatives are insular. If I have somebody who suffers from hypertension, and it is a chronic disease, I'm dealing in that little space. But when we're trying to look at the disease burden of a nation being lifted, then this information now must graduate from here to here. Now, what's being done to ensure that that is actually happening?
The macro level of intervention needs to be handled after we understand the size of the burden. So what I would say, even before I answer your question, is this country needs a digitized record, a digitized medical record. Because when we are going to community diagnosis, in the medical camps we do, you find we are having a lot of data gaps of even understanding what is the size of the disease burden. I'll give you an example before I land. In our last camp in Nyeri, we found the burden of hypertension there is over 23%, right? But you'll find the cardiovascular center, or the center of excellence of cardiovascular hospital, like Tenwek, is in Bomet, meaning the data is mismatching the provision of services. So when you're putting a cardiovascular center in Tenwek, yet Nyeri needs one, it means you've missed the data of where is the heaviest disease burden of hypertension. Because you find even cervical cancer, we need to have a cervical center in a place like Sega, Homa Bay, Siaya County. Because the prevalence there, when we've done early detection, because we do a lot of early detection camps as an intervention, you find out of 100 women, 65% of a certain age will be presenting with need for further checkups because they're presenting with HPV virus.
Hang on.
You understand? Which is crazy.
No, it's crazy.
Yes.
No, I just need to make a clarification, because essentially, okay, when folks decided that they were going to go to Abuja, in 2000 and, donkey years. It seems like so many years ago now.
2000 and leave it at that and continue.
And we continue.
Yes.
That it was upon this very premise that you speak of that they said, you know what, guys, this is the things that we are starting to see, and we need to have research. We need to make sure that the budgets of particular nations are actually going towards health research and towards health interventions. Everybody sat around the table and they said, fantastic. Abuja 1 happened, and then Abuja 2 happened. Abuja 2 happened, and the declaration was made. And African nations, almost all 54 of them, came out and said, you know what, this is true. We're actually going to do this, and we're going to make sure that our budgets go towards 15%, or 15% goes towards health. Now, whether or not that has been done remains a story.
No, it hasn't.
It hasn't been done. But this is essentially what would help, because when we look at these terrifying numbers, that if you look at one community, because Sega is not that huge in size in Siaya.
No.
But if you're looking at a community whereby out of every, what you're saying,
100
what
women.
you're saying, Daktari, sorry, not Daktari, I want to call you Daktari because Faith, that out of every 100 women, 65 are presenting with HPV.
Yes.
And
virus, which is a risk for cervical cancer.
And we don't have critical care scanning interventions in that area, for example.
And even we have vaccines. Controversial vaccines, but I believe in vaccines, and education needs to be done in that area because they're not controversial, but the controversy is introduced by people who are not understanding the information, that are expiring at the ministry or at Kenyatta Hospital, expiring in their 95,000, 100,000 vaccines expiring, when kids in that area, which is prevalent with HIV, need to all be vaccinated against HPV virus, because already when you have HIV, you're highly likely exposed and predisposed to cervical cancer. So, is our data segmented and stratified well enough? We need actuaries to come and be part of the solution and the intervention, so that we have predictive models that are helping have targeted solutions for different, because you cannot have a one size fits all for healthcare, especially chronic health.
Doesn't the Ministry of Health have actuarists?
I know it does,
yes.
But we're just saying we amplify their work and strengthen research so that we are having impactful decisions, because we find we export all our data. Yes, we collect data in a very fragmented way, export it to WHO, just to name what I know. And then WHO processes this data, returns it to us, and even sometimes after the big pharma has consumed it for their production, right? And then we now get 5 years later the results of this data, and we say our prevalence of diabetes is 4%.
You start with
it's
who
5
it
years
is,
old.
who sponsors the research in the first place.
That is the thing.
Yes.
So WHO has sponsored this research, then they deserve to have the data. But what happened to our own national registry, our own national data, where we have everybody with their patient history and the patient data in one particular database that the government can use?
You know, if you look at let's talk about the medical fraternity.
Yes.
And no, let's talk about our education system and at what point people come into contact with the concept and principle of research. And then look at how it is proliferated in our schools to institutions of higher learning and the focus that we give it. When you are a student, you will be required to do some research on a certain subject. And for many people, that is the last time you're actually involved in that process.
Before you graduate.
Yes. If you go for a master's program, you will need to do the same. But beyond that, this is manifest in our universities. You look at our universities, the research discussion is not what it should be for a research institution. So now, if we don't have that culture, when one leaves a learning institution and goes into the workplace, you are heading something in a ministry, whether it's agriculture, whether it's health, whether it's education, and that is not something you've given priority. How will you then treat research? Because in the absence of it, the credible data you speak of is not possible.
Very. And I'm so happy you've noted the root of the problem, because we start education on research too late on the trajectory of education.
Yes.
I'm a researcher by profession. I'm an actuarist and a researcher by profession. And I've done research. I've had the privilege of doing research in 16 African countries for the past 8 years. And I can tell you, from my experience, there are no local infrastructure to strengthen even the ethical collection of data, preservation, and protection than usage of this particular data to predict outcomes, because we are here to improve healthcare outcomes. I did not even mention the whole purpose of Chronic Disease Society is to improve patient journeys and to ensure that the health outcomes are good. Yes, you have diabetes, but it's not accelerating to something else. You know, most people you find have 2 or 3 chronic illnesses. They have diabetes, hypertension, cancer, kidney failure, you know, at the same time. Yes. And it's very, very...
And usually they are related.
Yes.
Yes.
They are all related. So if you manage your diabetes well, we will even reduce our cancer rates. If you manage your hypertension well, we will reduce our kidney failure.
Okay.
So I'll come to the numbers of that.
Okay.
What I'm trying to answer you on the research part is strengthening our ethical systems and digitizing. You see, the way when you're born, you have a birth certificate. That birth certificate has a unique number that no one else shares, right? Why can't we use that unique number to uniquely unify people and move with their patient histories from the time they are born all the way to mortality? You'll find we do data we collect data in reverse in Kenya. From my assessment, I could be missing some things here and there, but what I know, they collect mortality data.
We collect a lot of data. The question that you're raising is, what do we do with it?
Yes.
So even as we look at some of these issues and looking at the vanguards of these processes that we speak about, are ministries of health around the continent. And it just seems as though I wonder who went. I mean, we know that healthcare professionals, we know that research organizations, we know that governments went and signed this Abuja Declaration. We know that happened when we're talking about research and what needs to go. Because when we're talking about disease, the burden of chronic care, we are talking about what research has been done to know that, number one, you know the numbers of the people in the country who are suffering from heart disease. You know the numbers in the country of people who are suffering from diabetes. You know obesity and the more, what did you call them? Morbidities that come along,
yes.
comorbidities that come along with all of this. You know, and that is all heavily dependent on research.
Yes.
We hear this story that, you know what, we're dealing with heavy curative care. That means people are already sick, suffering, and dying. And that's where we spend most of our resources and our attention. But now they've tried, we've said, let's take this shift now and try to move it this way so that we are dealing with preventative and preventive care. But in order to do that, you need the numbers and you need the research. So it seems like a no-brainer to me then that you would then now invest in research, because now what you do is that you're able to then find folks before they get sick and then insert those interventions to ensure that your curative care burden decreases. Are we seeing that there's that move in that direction?
Albeit very slowly.
Okay.
We have visions, yeah? You can see the Ministry of Health is very ambitious. You've seen with the SHA model, right?
You laugh, so.
Yes. Because it's a very ambitious model. However, you find it's mostly capitalistic than social, because health is a human right. We can never approach it as a business, right? So if you approach health as a human right, first of all, the insurance or the reimbursements, like you have to make sure that the universal health coverage, if you're modeling the best universal health models in the world, like Thailand, which has been very successful in ensuring that this universal model, you find they're not depending on people paying premiums for insurance to be able to cover the community. The government should be able to have a fund, or should use the exchequer to cover the most underserved. You know, there should be a model that has been piloted, proven, and having predictive success.
I can bet you. I don't know. I don't know the people. I don't even know what it looks like, except for a few press conferences that we went to off your house. But I can bet you that somebody somewhere has written a paper, there's research, there's information, it's just waiting for implementation, sitting, waiting for some of these things to be done. Here we are talking about surveillance and mapping and things that need to be done to ensure that we are upping curative care in the country and across countries. And I keep saying, I have the privilege of being able to straddle two sides of the continent and being able to know what's happening here and
West
also
and
know what's
East.
happening here, West and East. And let me tell you, the issues are the same. Shakahola, there are 300 bodies sitting in a freezer outside Malindi Hospital. And the reason why we've not been able to identify them is because our research methods are still on the low. We don't have reagents, we don't have I don't know what. Now, if we can't do that for 300 bodies that have been in a freezer for close to a year today, here we are talking about how we need to make sure that the prevalence of obesity in the country needs to be monitored so that we can now implement research methods and make sure that those comorbidities don't affect hundreds of thousands of Kenyans. Tell me how.
Because we are donor dependent when it comes to research, and we look at research as a secondary solution, right? So we are not owning our own data. First of all, we are not even harvesting our own data ethically and using it to optimize our solutions. So first of all, we have, and I'm so happy, and I know some African states are happy that USAID is defunding certain programs, because we were only depending on that disease treatment and surveillance model. And then it was also very debilitating and vertical, as we said, because it was making us have so many gaps and neglect other prevalences and focusing on the policies that they have enacted for us to be able to earn those funds. So already the debilitating aspect is depending on outside help for our own research. You find there are so many contract research organizations that are foreign and they are saturated in our market. Like you said, they are proliferated. But our own local data is only exported, it's rarely processed locally with our own variable. We know the variables locally and the factors in African settings are very different. And you see we are adopting a lot of secondary data. We are adopting a lot of other models without making our own and trying our own based on, because let's say even diet, for example. African diet was admirable. It was the least processed. It was the most organic. The Paleolithic diet, like you see in the animals in Africa are still very healthy. Animals in Africa don't have diabetes. And I'm saying animals, let's say for chimpanzees, for example, in Rwanda, they are 99% DNA almost close to us, and they don't have diabetes. Why do we have diabetes? Because we've changed our diet. The animals have not. You understand? The lab rats, the lab rats that we use to do clinical trials and check for disease, they get diabetes because of what we feed them. So Africa, first of all, you have to go back home and authentically look, where did we start getting it wrong? When you say eating so much bread, so much Elianto oil, so much chips, because that refined oil has a lot of omega-9s, which we don't produce and we cannot counter unless we take omega-3 supplements, as discussion for another day. So already, by altering our diets, we predispose ourselves to other lifestyle diseases, which is also now marrying with other, deficiencies. That made us increase our chronic health burden. Urbanization has increased pollution, smoking, and all these sugar sodas that we take. And if you ask me, I would say the government should heavily levy these products. Number one, to increase their prices so that we reduce the disease burden. And number two, the levies should then go and fund health insurance. Yes, the levy should then go and fund health insurance so that you find our people who are underserved and underprivileged. The border menace. You see, most people who are sick of such lifestyle diseases are always in the towns. Nowadays, we go to villages, we go to counties. You find 40% of our mothers, our parents, are suffering from chronic illnesses. Arthritis is very heavy in certain counties. You find certain cancers are growing in their prevalence. Why? Because nowadays we no longer walk long distances. We eat 3 meals a day. Why do we need to eat lunch? Africans used to eat once every 36 hours, and we would live for long years. Yes, it's a myth, eating 3 times a day.
Every 36 hours?
Where is this where they eat once every 36 hours?
Every 36
hours is like 1.5 days, right? We would eat once. I'm talking 100, 200 years ago, because we had to hunt and gather our food.
Okay, right.
Right? So the process of hunting and gathering our food improved the resilience, the autophagy, where our bodies will clean themselves, and then we will automatically be healthy.
That discussion is really broad, because if I throw in the mortality rate, child mortality, I talk of mortality among adults, it was even higher in that period. And we'd say it is because of this and the other. The point you make is a valid one. The awareness that is sought is inadequate, I agree. What is daunting when it comes to healthcare seeking behaviors mostly is its cost. To be diagnosed so that you can determine what it is that you have or don't have, cost. Going to a health facility that has the wherewithal to determine this, cost. So, in many instances, when our citizens balance between children eating, going to school, and just the normal day-to-day activities and healthcare, unless they're feeling, you see, our determination of illness has to do with how we feel. So if I'm not feeling unwell, then I'm okay. And even if I feel slightly well, I'll self-medicate. So the role played by one, the absence of knowledge, which is often referred to as ignorance, and the balancing act that one has to do when you talk about limited resources, because the most limited of these resources, in my opinion, is not the economic capacity to do things, but it's here. Because everything you've said here, we talk about limited resources. when will we get it into our heads that we should utilize the resources we have optimally? As we talk of limited resources in this country, we talk about wastage.
Yeah.
We talk about expenditure that cannot be explained.
Yeah.
And they are huge amounts. So this chronic disease discussion is timely. I myself am diabetic. And I'm also hypertensive. Okay? I manage my diabetes through a diet. I don't take insulin.
He eats once every 36 hours.
Yeah. Are you on metformin?
On the who?
Metformin. Are you on any oral antidiabetics?
Nothing.
Oh, wow. So you've been able to successfully reverse.
He has.
Yes.
And you are now in remission.
That's what they call it.
Yes.
Then I must
There
be
are no flare-ups.
No, the flare-ups, no.
Okay.
No.
Then then we need to study you and understand what were your alterations. How did you pivot from your lifestyle choices? What did you change about your diet? Then you can even educate other people.
This is interesting. If you know, I can be the CT spokesperson.
Yes.
You know, we can talk about that.
Don't
later.
call him CT specimen.
The specimen one.
Specimen one.
Yeah.
Research human subject.
Sample, yes.
Research human subject.
001
Yes.
of 2025. So this was interesting because when this all happened, and you know, right here to be able to see that, and so we saw a CT who came from this way on a Thursday to then coming back, and it was a totally different way on a Monday.
Wow.
So it was cold turkey, literally, and whatever he was doing before stopped, and so and literally went from abundance to I'm not doing this anymore. So of course there was a
shift.
It was a total shift, and it was, you know, from here and saying I'm not going to do this anymore.
Wow.
But I think that we were able to see, and we could see that we saw the transition from one spot to another. And I do agree that something like that needs to be studied. And I think it segues us into where we are talking about today, that there is so much in terms of information, so much in terms of communication, a wealth of resource.
Yeah.
It's an overload, but we are not using it.
So
we are not using it. So who needs to come and say, I'm going to have a conversation with CT about what you were able to do that's going to be able to help somebody else?
The government.
But I have to explain this so that I give it context.
Yes.
I knew I was hypertensive, but I had to collapse and be taken to hospital.
From here, yeah.
For
You
me
had your Damascus moment.
That wasn't Damascus, it was a Red Sea moment.
And I'm happy you're sharing your story, really.
Yes.
Because let me tell you, out of every two, the statistics are very glaring. It's a stark disparity in our statistics. Out of every two people, one is highly likely to get diabetes or hypertension.
Yes.
So we are looking at 50% prevalence. If we do early detection, you know, some people are pre-diabetic and they live with it 10 years before now the big diagnosis, then they say I have it. So at least you're lucky enough to get it early, be aware, and then now reverse it through early detection and patient education and then self-management. So we need to incentivize that.
But imagine, for instance, if I was not able to be taken to hospital, I would, if I hadn't collapsed, I would not have known I'm diabetic.
I'm so sorry.
No.
And that happens to many of us because when we go for our medical camps, you find people only realize they have cancer at the late stage when they are 1 week away from death. People only realize they have diabetes when it's already progressed to kidney failure.
Yes.
So the late diagnosis burden is what we're trying to reverse. Early diagnosis, early detection is what we do most. We do community diagnosis. We go, we create awareness within a village. We go, and we need to really involve CHVs in
healthcare seeking behavior. Essentially, needs to be
improving the healthcare seeking behavior by integrating it in our organizations.
How do you get people to actually go and get tested? How do you get people to actually go for health checks?
First of all, we go to the people. As Chronic Disease Society, we go to the people, as many as we can. And we need to multiply that effort through now what you guys are doing today.
When you go to them, what do you do?
We ask them to do screenings. So we do what we call medical screenings and health checks. Then we do health talks.
So you actually have a medical camp?
Yes, we always do a medical camp. As frequent as possible. Now, when we establish there's a burden of a certain disease in an area, we can even camp there for a full week.
Let me ask the question. After you leave, what then happens?
Then we refer them to care. We link them to care.
That is where now that gap comes in, because they know they've been told. When I talk about the cost of these non-communicable diseases, there is a cost, and a rather steep cost.
Very.
Now, do we then talk, the preventative aspect then spoke of, do we talk about how to mitigate, how to ensure you don't get there?
Yes. So prevention strategy is very interesting, and we have to be already there. We are too late to the prevention awareness and campaign. And number 2, we need also to check and have a performance-based model where our hospitals are also not taking advantage of the people who are already chronically ill, because that's a forever lifetime client. So we need to have capitations on such, so that insurances can incentivize those who are doing preventative care, at the same time reward the patient-centric model where hospitals are, should I say, appraised by the patients, so that it's a care-based model rather than a profit, because once we go, like I said, healthcare is a human right.
Right. But that's at the policy level. Sorry, Dennis.
Yes,
That's the policy level. And this is the thing that we're hoping that could be an umbrella policy around some things, that we know that some policy has to be specific, but that there can be umbrella policy whereby you're saying that this must be the case. And that's why I do agree with an overall levy, for example, for health.
Yes.
That it comes out of what you spend,
Yes.
whether you register or not. It comes out of what you spend. This money is ring fenced, and it goes directly to this thing, because that's one of the ways in which you can do things like this. That's why, for example, and I sometimes hate to use the example, but that's why people like Michelle Obama were able to stand up and say, let's do a proper school feeding program whereby children are not eating junk, that they're now eating healthy meals, because they do provide food in schools, that they're eating healthy meals. And what do? It's preventative care right from the child.
And I agree with you, because the absurdity of our system is, you can imagine, we are calling people to register and on board on SHA. You should be already onboarded on SHA by virtue of being a citizen of Kenya. That's why we are calling for a digital registry that is universal, that starts from the time you're born, because most of us are born in a hospital. So you're already onboarded on that, and then your patient history, that unique identifier, works with you every time, so that when you go to any hospital, any doctor, so long as you have given that PIN, can access your patient history.
Indeed.
That will improve even for planning and the level of burden, knowing this population is high risk of this and this. Then once, like if you model the Cuban model, where you have a family doctor who knows your grandparents had diabetes, your parents, so they already prepare you to prevent this based on your patient history. So all this comes down to data and research.
Yeah, pretty much it was just for the sake of the conversation. I mean, we'll talk about what needs to be done. You look at the government policy in terms of universal healthcare that is there. We have it, but is it working? Is there intentionality in making sure that all these processes do work? We talk about NCD clinics and specialized centers taxing unhealthy products, because we talk about the sugars, the sodas and whatnot. But then again, even when we tax them, where do these funds go? Like Sitia said, we take these tax and put it into put them into healthcare to respond to these disease burdens that we do have. Like, for example, we have taxes on sugar. Where does it go? Do we take it back to our healthcare system to help with what it is we're talking about today? Or we're just taxing for the sake of raising revenue, then spend it on what? Wastage that city is talking about. But then again, how do we have this conversation with people like you to ensure that the government understands the disease burden and does right by the people?
That second bit, they do understand the bit.
So it's integration of solutions, because you've asked many questions. let me try to remember the first one.
Answer one in a few seconds.
So we need a foolproof pool to fund the chronic care, because you find we are pulling from a risk pool where you're depending on people to contribute who have jobs to contribute. So I agree with you when you say the levy, like levy goods that are coming from outside. We can borrow a leaf from Donald Trump, unpopular opinion, and tax some foods that are coming literally to kill us, because they really have zero nutritional value. We don't need direct sugar in our body.
No. We have
taking direct, and you can eat a sweet potato and the sugar will be processed organically by your liver. But now, when you are drinking the sugar, the body is confused. It's too much.
Exactly.
Yeah.
Look, there's never enough time to have conversations like this. I think it's very necessary that we do what we do with these conversations, that we put them front and center of the attention of those who craft policy and then implement it. Very important for us to have, especially now when the disease burden is so heavy. So we want to thank you so much for being here with us this morning, and we're looking forward to another time when we can do it again. The chairperson of the Chronic Disease Society of Africa, Faith Okwisa Okwayo, has been here with us this morning.
Thank you.
And we want to say thank you.
Thank you so much for having me.
It's great to have you here.
Santi.
Good morning.
This is the Situation Room, the only way to start your day.